You are so warmly welcome to this medical education session. We today are going to be covering a really important topic, which is cancer cachexia. And we have got an amazing speaker for you in Professor Barry Laird. Before we begin, I'm just going to bring up our disclosures so that they're on your screen, and that's really important that we share them with you. Please take a read of those. They're also available in the program information, which you'll have seen before you joined. We are going to be covering two learning objectives in today's session. We're going to be learning how to recognize and diagnose cancer cachexia earlier and more consistently across cancer types. And we're also going to be learning how to implement evidence-based multimodal strategies to support appetite, lean body mass, and physical function in patients with cancer cachexia. If it's the first time you've joined us, you are really welcome here. We are really passionate at Medal to run free, open access medical education that's globally accessible. And wherever you're joining from today, we hope that you find this a really useful session. We also like to start off our sessions with some cases and some polls. So I'm going to bring those up on screen just now. And these are to help us all understand where we're at in our learning journey, but also to start to frame what we're about to learn today around patients and cases that we can apply some of this education to. What I'd really love you to do is to answer these polls. So I'm going to bring them up. You'll find them in the chat box on the right-hand side if you're on desktop. You'll find them via a little message icon if you're joining on mobile. If you're joining us on one of the social platforms, you've got to join us on Medal, and we'll show you how to do some case-based polling with us. So the first poll that we're going to do is this one. A 64-year-old man with newly diagnosed stage 4 pancreatic cancer presents for follow-up. Over the past 3 months, he's lost 6% of his baseline body weight. His BMI is 21. He reports early satiety and fatigue. CT imaging shows reduced skeletal muscle area consistent with sarcopenia. Which of the following best supports a diagnosis of cancer cachexia in this patient? And I'd love you to answer A, B, C, D, or E. And if you can share your thoughts in that poll, that'll be great. And hopefully as we go through the education today, all of this will become clear. So if you don't know the answer, don't worry. By the end of our session today, hopefully you will. And we're going to be doing a few more polls, so you've got an opportunity to share a little bit more of your knowledge as we go through. So if you're just joining us, we're doing some polls. If you can pop a little answer on the poll that we've shared, it's in the chat box on the right-hand side on desktop. Click the little message icon on mobile, and you can scroll up and answer all of our polls. So even if you've missed the first one, don't worry, you can scroll up and still answer it. Okay, the second poll that we're going to ask is this one. Which of the following bedside or system level strategies is a practical method to improve consistent cachexia screening in oncology care? A, B, C, D, or E? If you can pop an answer into the chat box, into the poll, sorry, that would be great. And if you're just joining us, you can answer all of our polls. You can scroll up and answer them in the chat box on the right-hand side of your screen. And you'll be able to join using the chat box on mobile, the little chat icon at the bottom. Okay, the third poll is this. A 58-year-old woman with advanced non-small cell lung cancer starting systemic anti-cancer therapy is enrolled in a program modeled after the MENAC trial. Which combination of interventions is most consistent with the evidence-based multimodal approach? Is it A, B, C, D, or E? If you can pop an answer into that poll, that would be great. And you can scroll up and answer all of the polls on the right-hand side in the chat box. If you're joining on mobile, you can click the little message icon. These are to frame what we're learning today around patients and begin to get us thinking in that mindset. Okay, the next poll is this one. Which of the following healthcare professionals should be routinely engaged to optimize cachexia across stages? A, B, C, D, or E? Great, thanks everyone for popping some answers in. If you haven't answered all of our polls, please scroll up and give us an answer on our polls on the right-hand side. And we'll then hopefully begin to frame our education around our patients today. Okay, and I've got two questions that I want to ask you, and these are not case-based, but it's just to understand where you're at. At the moment, how confident are you in applying validated diagnostic frameworks and practical tools to recognize cachexia earlier and more consistently across cancer types? 1, not confident at all, right up to 5, very confident. If you could let us know, that would be great. And we're going to be covering these topics during our session today. Thanks, everyone. Okay, and the second confidence poll and final poll before we get going is this. How confident are you in implementing multimodal, multidisciplinary strategies to support appetite, lean body mass, and physical function in patients with cancer cachexia? 1, not confident at all, right up to 5, very confident. If you can give us an answer, that would be super. And if you've just joined us wondering what's going on, we're doing some polls. They're mostly case-based. They're in the chat box on the right-hand side of your screen if you're joining on desktop. They're in the little message icon if you're joining on mobile. If you're joining on socials, you've got to join us on Metal, but you'll be able to join in polls next time if you join on Metal. If you haven't answered all of them, you can scroll up and give us an answer on each of the polls before we begin. That would be super. Okay, we are going to dive into some incredible education, and it gives me really great pleasure to introduce our speaker today, who is Professor Barry Laird. And Professor Laird is Professor of Palliative Medicine at the Edinburgh Cancer Centre and St Columba's Hospice, and he's part of the Edinburgh Palliative and Supportive Care Group. And he is going to be talking to us in 2 parts today. And the first part is going to be about recognizing and diagnosing cancer cachexia. I'm going to hand straight over to Professor Laird, and we're going to dive in. Professor Laird.
My name is Professor Barry Laird, and it's a pleasure today to give this talk on cancer cachexia, entitled Early Recognition and Comprehensive Care. These are my disclosures. And the learning objectives for this short talk are to try and recognize and diagnose cancer cachexia earlier and consistently, to apply validated diagnostic frameworks and integrated bedside and EMR tools, so electronic medical record tools. So what is cancer cachexia? Well, you've all seen it. It's a condition that affects people with cancer, with heart failure, with end-stage chronic obstructive airways disease, and other conditions, usually towards the end of life. And what it looks like clinically is patients become increasingly weak, fatigued, they have a reduced appetite, and they become refractory. And that means essentially they're not responding to cancer treatment. And this was initially described by Hippocrates, actually 2,500 years ago. And cachexia comes from the Greeks for, wasting in bad state. So it really is a bad state. And in terms of, technically defining it, well, efforts have been made over the years to try and bring together some form of consensus. So this study here, or this paper here, shows a nice figure of what cachexia is. So it goes from a pre-cachexia stage to cachexia stage and a refractory stage. So a key point with this is that cachexia is not just one single point in time. It's really a transition that patients go from having maybe minimal or no weight loss, but they have the underlying metabolic change, right through to a degree of cachexia, where they have a more greater degree of weight loss, or they can have a low BMI, and they often have reduced food intake with systemic inflammation. And in the final stage is refractory cachexia. So this stage, the cancer disease is usually pro-catabolic, not responsive to treatment. And at this point, survival is usually reduced to less than 3 months. So a key concept is that cachexia is a spectrum of a condition. It's a technical definition here is a multifactorial syndrome characterised by an ongoing muscle loss with or without fat loss. So just pause there. So the key concept with this is it's ongoing muscle loss, but you don't have to have fat loss. And that's important because we know that loss of muscle will adversely affect outcome. So if you lose muscle in your legs, you lose muscle in your arms, you lose muscle in your chest wall, you lose muscles that help you to breathe properly. And you lose your heart's a muscle, so you start to lose cardiac tissue too. So this loss of muscle is potentially much more damaging than loss of simple fat. That's the first key concept. The second key concept is it cannot be fully reversed by nutritional support. Simply giving people who have cachexia more energy or more calories is not enough to fix the problem. The final key comment is that it leads to progressive functional impairment. Patients become weak, increasingly unable to do their general household activities and interact with family members. So that's what it looks like. Weight loss, usually muscle plus or minus fat. You can't fix it just by giving people more calories, and people become weaker till ultimately death. What's going on in the background of this clinical phenotype? Well, it's an abnormal metabolism. There's a negative protein and energy balance, essentially the body using up many more calories than it's consuming, and also combine that with reduced nutritional intake. So this has been sort of working definition for the past 14 years, and this was set up really as a sort of starting point to try and progress the cachexia research agenda. However, there's been various attempts to try and refine this over the years, and this is quite a nice paper published called Cachexia and Cancer, What's in a Definition? And what they did here was they took two different types of cachexia definitions. The one is the Fearon criteria, which is the top one you see here, table A, and the bottom one is the Evans criteria. Now, in both of these criteria, they use some similar features. But quite interestingly, in the Evans criteria, they include a marker of systemic inflammation. Now, remember, the previous slide, I talked about cancer cachexia being driven by an abnormal metabolism. So in the Evans criteria, they tend to incorporate this abnormal metabolism aspect by looking at systemic inflammation. And you can see here on these two Kaplan-Meier survival curves, the top one being the Fearon, there's a clear difference in survival between patients who have no cachexia versus cachexia. However, in the Evans definition, this disparity between the two groups is actually quite dramatic. So essentially, including inflammation in the definition of cachexia is a key component in prognostic outcomes. Now, we could take it even further than that definition. This is a colleagues in Glasgow wrote this paper saying, let's look at a simple objective framework. They developed a score called the Glasgow Prognostic Score, which combines albumin, which is a marker of nutrition, C-reactive protein, which is a marker of systemic inflammation. And they developed a simple framework going from a score of 0 to 2, the Glasgow Prognostic Score. So intentionally, a score of 0, somebody has either albumin at normal level and reduced C-reactive protein. Well, we've got some weight loss is not common and generally no metabolic upset, so no intervention is needed here. For the next group of people, they have a lower albumin, slightly lower than the reference range, but again, their C-reactive protein is normal. For these patients, they've got some weight loss, but there's no metabolic upset. In other words, the sort of background biological changes of cachexia haven't happened as yet. In these scenarios, it's essentially just a case of trying to improve their nutrition via dietary interventions. But once you go up to a Glasgow prognostic score of 1, when patients have a raised C-reactive protein, now we're saying these patients are now systemically inflamed, then it's important there that they actually consider some form of dietary intervention and also maybe some anti-inflammatory treatments. The final stage really is Glasgow prognostic score of 2. People are hypoalbuminemic and they're also systemically inflamed. In these patients, they have both severe weight loss often and metabolic upset. In these cases, potentially the main treatments should be dietary intervention, but also referral to supportive or palliative care for guidance. So this is a very simple way of categorizing patients using a sort of biomarker-based approach. So really what you can see over the last 14 years from the the theorem definitions through the Evans in this sort of simple cachexia framework proposed by Macmillan, etc. This has started to inform the guidelines that are widely used. So the ESPEN guidelines in cancer nutrition, which put the paper up here, these are the most highly cited guidelines in the area of cancer nutrition. And they talk about patients and a call to action for patients with cancer. So a key thing they say is they should screen all patients with cancer for nutritional risk early in the course of their care. So every single patient who's got cancer should be screened for nutritional risk. And it shouldn't make a difference depending on their body mass index or weight history. Even if somebody's overweight or has a high BMI, they're still at risk because cancer cachexia is predominantly loss of muscle. So it's important that we screen for these people irrespective of their body mass index or weight. Indeed, some people would argue that body mass index is actually quite a poor measure. And it's also important to bear in mind that in the Western world, there's a lot of people who are overweight. So we have a thing called sarcopenic obesity, patients being overweight, but actually can still be losing muscle. They also say that we should increase nutritional assessment. And in that, they are quite clear that we should include measures of systemic inflammation. In other words, the biological changes that are happening in cancer cachexia. And they suggest the Glasgow Prognostic Score for that. And then ESPEN guidelines also say nutritional interventions should be individualised to suit that patient, their dietary needs, also their cultural needs, their socioeconomic needs. We should be focusing on increasing nutritional intake, decreasing systemic inflammation and hypermetabolic stress, and increasing physical activity. And the reason we want to increase physical activity is because that helps maintain muscle or even promote muscle buildup. And also, if people are eating more, as they're exercising more, you get postprandial anabolism, which is essentially the muscles building up after meals, and that's a beneficial concept. So there we've gone from this a rudimentary definition to the importance of inflammation and now a clinical guideline. Now to take this even one step further, the GLIM group, so that's the Global Leadership Initiative for Malnutrition, have produced this concept of identifying people with malnutrition. So in this sort of schematic here, they talk about risk screening. To identify subjects with risk factors and then do a diagnostic assessment. So it can be non-volitional or involuntary weight loss, a low BMI, or low muscle mass. It's a phenotypic, so how somebody looks or what's happening to them. And then also a sort of etiological aspect, such as do they have reduced food intake or a condition or disease that's typically associated with inflammatory activity. So they advocate that for criteria for malnutrition to be met, you need one phenotypic criteria, such as say non-involuntary weight loss, and one etiological criteria. And then they would have based the severity of the malnutrition based on the phenotypic criteria. They've put it in a very sort of simple format as well on sort of guidelines and terminology, because if we appreciate, as we've started this talk today, and we've talked about cachexia, we've talked about nutritional risk, we've talked about malnutrition, and you might be thinking, how do these concepts all connect together here? Well, if you like, the best way to think about it is malnutrition or undernutrition being a sort of overriding term. And when you get into different sort of subtypes of that, they classify it really as disease-related malnutrition, so caused by a condition either with inflammation or without inflammation. So if you go down this column here, you can see here that you've actually got disease-related malnutrition with inflammation, and if it's chronic disease-related malnutrition with systemic inflammation, they go so far as to say that it's cancer cachexia. So that is actually what they're saying. If you've got disease-related malnutrition, in other words, malnutrition on the background of a condition such as cancer, and you're systemically inflamed, they would see that as cancer cachexia, which fits with all the work that's been done thus far. So taking this a step further, GLIM have actually gone as far to say that inflammation should be measured by C-reactive protein, and that's actually one of the assays that's the most standardized all over the world. So CRP aligned with something like weight loss, a chronic disease, and also reduced appetite. If CRP is raised with those sort of factors around it, you can be pretty sure that the patient has cancer cachexia. But yet it's quite difficult to really screen for this in the clinic. There's a lot of different barriers that exist. There's patient-level barriers. So people don't like to have lost weight when they've got cancer. They know that's a bad thing, and they know also that that can become a huge emotional burden for them and their caregivers. So there's often a big fear of when we talk about the patient losing weight, it can induce a lot of stress for families. Sometimes there's a cultural belief or misconception that actually when you lose weight, it's a good thing. But actually, in this field of cancer, generally losing weight is not a good thing, as it can affect a lot of aspects. And essentially, people are losing tissue at a time when the cancer is also, augmenting tissue loss as well. And patients also can underreport appetite or fatigue, so they don't want to tell you that they've lost weight or they're overtired, or their clothes are potentially getting a bit too big for them. So these are sort of patient-level barriers. In terms of sort of provider-level barriers, well, there can be some oncology gatekeeping. By that, I don't mean that oncologists don't understand how important cancer cachexia is, but they do have a short period of time usually to discuss various aspects within a consultation. And to bring up something like cachexia, it can't be dealt with in 2 or 3 minutes. So in some ways, it's a lot of work to bring something up. But maybe something greater than that is the fact that there's not easy to manage treatments and guidelines for it. So are you essentially highlighting a problem that may not have time to do, or there may not be good enough treatments for? There's also knowledge gaps. A lot of doctors and other healthcare professionals aren't aware really what cachexia is. As you've seen today, some of the terminology and the nomenclature can be quite confusing, so that's not helped matters. And also variable practice patterns happen as well. So for example, in fields like breast cancer, cachexia is not terribly common, whereas in such like lung cancer, pancreatic cancer, this can lead to discomfort discussing cachexia where some clinicians are not as used to it. There's also some system level barriers. There's usually no electronic medical records prompts or flags. Workflow is often fragmented. So, for example, dietitian care and oncology care rarely go together in the clinical setting. When somebody goes to the clinic, there's rarely see a dietitian alongside. So that fragments things. And there's also time constraints and resource limitations as well. So how can we overcome these? Well, one of the things that I'm often told is it's important just to acknowledge there's a problem. That's a huge relief for patients and their caregivers. Give it a name, call it cancer cachexia, say what it is. To try and improve workflows and protocols, to integrate medical records with alerts so we can start to see when patients lose weight and aren't doing so well, and work together as multidisciplinary teams. Cancer cachexia is not a dietitian problem or an oncology problem or a nurse problem, it's an everyone problem. So I think we've all got duty as healthcare professionals to try and address this and implement management strategies. Thank you very much for your attention.
Thank you so much, Professor Laird, for an incredible first session. We are just pulling up a QR code on the screen right now for you, which will allow you to claim your CME certificate. You might need that later on in the session. We'll also be popping the link into the chat box for you, so you can click on that. If you have to dip out early, please still give us some feedback. We'd love to hear that in the evaluation and feedback at the end. You'll be able to get that via the QR code. It's really important. We're really passionate to make these sessions as good as we possibly can. So if you have to dip out early, please scan that QR code. Please still give us some feedback. We have got another learning objective to cover today, and then we're going to be diving into live questions and answers with Professor Laird. So if you've got some questions that you want to pose to Professor Laird, please pop them in the chat box and we'll have an opportunity to pose them to him after his second talk. His second talk is on our second learning objective today, which is around multimodal strategies to support appetite, lean body mass, and physical function. I'm going to hand over to Professor Laird for this second session. Professor Laird.
I'm going to cover these 3 learning objectives: implementing multimodal interventions, coordinating multidisciplinary team management, and monitoring outcomes and adjusting plans. This is a companion talk. My previous talk looks at methods of cachexia diagnosis and screening. So, principles of management. As we've learned from my previous lecture, cancer cachexia is a multimodal problem. By that I mean the biology that's surrounding it is complex. It's not just simple lack of nutritional intake. It's not just simple loss of muscle. It's not just simple metabolism changes. It's all of these things together. So when you have a complex problem with multiple different pathways that will result in it and different types of clinical phenotypes, it's really important that we address all these factors in unison together. So it's rare that we're going to have one single medication or tablet that's going to fix this problem. Second thing is our goals. Well, ideally, we'd like people to gain weight, gain function, improve their quality of life and independence. But a goal can also be to preserve function, preserve quality of life, and preserve independence. And I think that's a reasonable thing to aim for. It might be always difficult to stop people losing weight and reducing their physical function, but it's maybe less aspirational to go for something that's preserving function. You don't be too hard if you're looking for increases in weight, increases in physical function. And also it's important to think about stage-specific interventions. So what's right for somebody at the start of their cachexia trajectory when they have a pre-cachexia phase might be quite different from somebody in the refractory cachexia stage near the end of life. So what we're very good at doing in oncology is we're very good at staging cancers and treating cancers. And in the last 10 or 15 years, there's been a huge step change in the positive improvement outcomes of multiple cancer types. So we think of hitherto cancer types before, such as lung cancer. Lung cancer is a great example. Myeloma, for example. Patients now with these diseases are living for many years. Patients with stage 4 lung cancer are now living for 2 or 3 years, which was unheard of 5 years ago. So we're really getting good at treating cancer, staging the tumor, treating the tumor. But what we're not very good at is staging the host and treating the host. Now, by staging the host, I mean staging the patient. What stage is that patient at? Has that patient lost a lot of weight? Are they functionally compromised? Are they very weak? Have they got a reduced appetite? Have they got multiple symptoms such as pain, low mood, constipation? So we have to think, what is the patient like? How are we going to stage the patient? There's various ways to do this. You can do it through a sort of functional status, such as ECOG performance status. You can do a biochemical status, such as using an inflammatory score, such as the Glasgow Prognostic Score. The important thing is that we should be staging the host or staging the patient alongside as we're staging the tumour. And if we're going to stage the host, we should treat the host as well. So what I'm going to do in the next section of this talk is talk about some different modalities to try and treat the host, to treat cancer cachexia. And really, if you think about it, if we do these things together, treating the host and the tumour in unison, I think we're likely to get better outcomes for all involved in this. So actually optimizing the condition of the patient will hopefully result in the more efficacious cancer therapy. So let me give an example of some multimodal interventions. So I said to you that cachexia is a complex biology. Well, this schematic here is a very simple sort of depiction of that. But on the top, you've got the tumour and how that reacts with the host. And that releases lots of cytokines, so inflammatory hormones, cachectic factors, and also it produces endocrine dysfunction. You'll see here, this is a wide-reaching effect, ranging from the brain to adipose tissue, to muscle tissue, to liver, to gut, and affecting glucose metabolism. I'm not going to touch on all of these, but one of the key aspects is its effect on the brain. Now, you wouldn't think the brain would be involved in something that really was a weight loss thing. You would think that was more, gastrointestinal, but actually a lot of cachexia is driven from the brain. Brain can result in anorexia. These changes can result in anorexia, chemosensory changes, adrenergic activation, and increased hypogonadism. And they all result essentially in muscle tissue loss and adipose tissue loss as well. So really the brain is one of the key drivers in cancer cachexia. Another key driver is the liver. The liver really acts as sort of a bioamplifier in cancer cachexia, taking a lot of these inflammatory signals and enhancing them and amplifying them around the body. So it's a complex phenomenon and results in essentially people with reduced food intake, reduced muscle, increased inflammation. Now, if you think about a simple way of doing this and breaking it down, well, if somebody's not gaining weight, we can give them some increased nutrition. So a study that was done called the MENAC trial, which was multimodal evidence nutrition and anti-inflammatories for cachexia. where we give patients in a randomized trial a multimodal intervention versus standard care. And the multimodal intervention involved dietary counselling, exercise, both aerobic and resistance exercise, ibuprofen to downregulate inflammation, so simple ibuprofen, omega-3 oral nutritional supplements, so fish oils, which again are naturally anti-inflammatory, but all importantly, alongside systemic anti-cancer therapy, treating the cancer at the same time as we're treating the cachexia, not afterwards, but in line with and parallel with treating the cancer. So this MENAC trial, as I say, we diagnose people with incurable non-small cell lung or pancreatic ductal adenocarcinoma that were starting systemic cancer therapy. And importantly, we didn't have to have people losing weight to take the trial. We made the assumption that these patients were at high risk of cancer cachexia and were going to lose weight. So we thought we were going to try and prevent the development of it or slow its progression. We did this study that people were randomized equally between the intervention arm, which was their multimodal treatment, or standard cancer care. And we assessed patients after just 6 weeks. Our primary outcome was difference in weight change, and our secondaries were difference in muscle mass and physical activity. So these are results of those two aspects. And in terms of change in weight, the pink sort of bars on the chart are the multimodal treatment, in other words, this intervention of ibuprofen and nutritional supplements, etc., versus treatment as usual, which is the blue line. And you can see here, there's a clear difference in the percentage weight change between those two groups to levels of statistical significance. Now, with regarding our secondary endpoints, there was no statistically different changes in muscle count, muscle mass, or also their physical activity. And there can be many reasons for that. But the other aspect to say is the whole process was relatively safe. So this trial really was the first big trial to try and sort of target this multimodal biology of cancer cachexia. The intervention prevented weight loss, and it was a real-world data and a pragmatic trial on the background of changing cancer treatments. So we would wonder if this actually could be a background for optimal cancer care and new therapies in the future. Now, in terms of nutritional interventions, I spoke to you at the start to say that some people, that are people with cachexia, simply giving them nutritional supplements was not enough. Now, there's a lot we know about nutritional interventions, but there's a lot we don't know. This chart here shows is patients with cancer across different tumor types. And this just shows you across all these tumor types the different numbers of patients who had nutritional problems, unintentional weight loss, or they felt they had lost muscle. So it's quite high. It's specifically high in some groups, such as the lung groups and the head and neck cancer groups. You can see it occurs across all cancers. Now, what is interesting if you think about the nutritional care people get, it's not really based on any high degree of evidence, and there's no standard of care. So if you're a breast cancer patient in one hospital versus a breast cancer patient in another hospital, it doesn't mean you get the same nutritional interventions. You might not even get any nutritional interventions at all. Studies of nutritional interventions have produced mixed results, and how we screen for nutritional status and body composition has been inconsistent. And there's no real agreed minimum cutoffs or screening questions for this. Another thing we know is that sarcopenia, so loss of muscle, is associated with increased toxicity from chemo or immunotherapy, so-called systemic anti-cancer therapy. But research in nutritional interventions in cancer malnutrition is limited. There's no coherent intervention, and we don't know, if what works well in breast cancer works for gastric cancer. We don't know when we should give it. Should we give it before treatment, after treatment, during treatment? And should we try to tailor our interventions? In other words, if somebody's lost a lot of muscle, and should we think about giving them an intervention that tries to promote muscle buildup rather than actually give them something that just produces calories? There's a lot that's still to be discovered in this area. In terms of pharmacological therapies, well, there's supportive therapies, and a thing to bear in mind is that a lot of you would think of non-cachexia symptoms will actually affect cancer cachexia. For example, if somebody's got poor pain control, that will influence their ability to eat well and mobilize. If somebody's got nausea and vomiting, you might have to think about giving them some medication to improve their appetite. And if they've got a low mood, they don't feel like eating as well. So think about treating, depression or anxiety. And also optimizing the fatigue. So if they're anemic, consider treating that. Obviously managing their sleep hygiene and getting them to do regular physical activity. In terms of actually drug therapies for cancer cachexia, well, there's appetite stimulants. The megestrol acetate is the one that's the most studied, and it tends to improve appetite and a modest increase in weight. It doesn't really cause muscle buildup. And muscle buildup is probably more important than fat buildup, and it can have some side effects. The other drug that's quite often used are corticosteroids, such as dexamethasone. They work short term to give patients a bit of an appetite and energy boost, but the benefits wane after time, and they also can cause quite a lot of side effects, particularly muscle wasting, which we know is a bad thing in cancer cachexia. There's also some emerging agents such as ghrelin receptor agonists. So ghrelin is a hunger hormone, and there's agonists to this which actually act like ghrelin, which cause increased food intake. And some trials have shown that they increase lean body mass, so that's muscle, and also can improve quality of life. But these are not widely available at the moment. Now, what was quite exciting recently was a study produced looked at a drug called clonsegramab, which was a drug against GDF15. And in this drug, they looked at 3 different doses versus a placebo arm, 100 milligram, 200 milligram, and a 400 milligram arm. And you see here versus a placebo. And you'll see here that patients on the different arms all gained weight, but patients on the higher dose arm gained almost 3 kilograms over 12 weeks compared to placebo, with really no huge difference in adverse events. So this drug, GDF15 drug, the targets is called clonsegramab, has got potentially some exciting future ahead of it. But for us to really think about how we're going to treat cachexia in a sort of holistic way, we need to do more than just think about drug trials. We need to think about animal models and cell models to try and enhance our understanding of the genetics, the proteomics and metabolomics around cachexia. We need clinical trials, much more clinical trials, and I think that it should be a mandatory right that all patients have access to a cachexia clinical trial, and that's not the case at the moment. We want to encourage drug development and also look at aspects of body composition, which can be measured easily in the clinic. In the clinic, we want to make sure people are aware of what cachexia is, how to diagnose it, how to assess it, and do basic cachexia management. And as I said earlier, this is a remit of everybody in the healthcare team, not just dietitians or nutritionists. And the final thing we need to do is educate people. There's a lot of emerging now support groups for cancer cachexia, some consumer panels and outreach events. We need more and more patients involved in this area to try and drive the agenda, to push the research, and really make a mandate for improved cachexia. And if we do all those sort of things together, there will become a sustainability in the cachexia landscape going in the future. So in summary for cachexia, early recognition is critical. Bedside tools and prompts help identify cachexia, but barriers exist and they can be overcome. Multimodal management is key, and this might serve the basis for other drugs to be tested alongside this. And multidisciplinary coordination, oncologists, dietitians, physiotherapists are really needed to optimize care. And also, as I said, cachexia really is a syndrome that changes over time, and we might adjust our treatments depending on the stage of the disease that patients have. Thank you for your attention.
Thank you so much, Professor Laird, for an incredible 2 sessions and for so eloquently covering our learning objectives today. I'm just going to bring up on screen a QR code which will allow anyone who's joining, and if you've got a nip off early, please scan that QR code and give us some feedback. And it will also allow you to claim your CME certificate. We've got some time for questions and answers, so if you've got some questions that are burning for you, please pop them into the chat box. This is a great opportunity for a bit of discussion, so please pop your questions in there. Please scan that QR code, give us some feedback, and claim your CME certificate if you've got to nip off early. We're really honoured to have Professor Laird join us live for questions and answers. Thank you so much, Prof. Laird. We're really grateful for your time today.
Thank you.
We have got some questions from the audience across all of our channels at the moment. Interesting question from Ahmed Gusem. How important is mental health in increasing the chance of a positive prognosis for a patient with cancer cachexia?
Yeah, that's a fantastic question. I've never been asked that before, and I've been asked a lot of questions about cachexia. Um, so hugely, the we know that patients and their caregivers, there's a huge degree of psychological stress that comes along with having a cancer diagnosis, but also having loss of weight and loss of appetite, because the social aspect of eating and is really integral to most of our daily lives. So acknowledging it as a problem and also trying to, improve these symptoms. So, for example, if someone has a fairly severe depression or anxiety disorder, that will affect your ability to eat. So really, we should be thinking about treating these conditions alongside cachexia because they're all multifactorial and all interrelated. So, yeah, mental health, clear issue, needs raised and treatment started appropriately.
And we've got a question about the MEMAC trial, which is the MEMAC trial data was very interesting. The multimodal intervention successfully prevented weight loss, but didn't show a statistically significant impact on muscle mass or physical activity. How should we interpret this finding? And does it suggest the intervention primarily preserved fat mass, and what modifications, like intensive resistance exercise or different nutritional targets, might be needed to specifically protect muscle?
Yep. So, I think the interpretations of these data from MENAC, the trial was done over a 6-week period. Most cachexia trials now are done over 12 weeks. So I postulate that potentially we reached our endpoints slightly early. If we assessed that again at 12 weeks, we may have seen better changes, number one. Number two, during the course of the trial, there was quite a lot of changes in cancer therapies. For example, at the start of the trial, immunotherapy for lung cancer wasn't that commonplace. By the end of the trial, it was the most common therapy. And these treatments are likely to have impacted other aspects of the outcomes, such as lean body mass, for example. The third um, the third aspect, I think, is that, we don't really know fully the interplay between all these different cancer therapies and body composition data. So that's something we'll need to look at in the future, and the full sort of findings of the MENAC will be published in the coming months, which will give some more granularity as to some of the aspects. Um, Phil, I think there's one other aspect to that question I maybe didn't answer. Could you just repeat the last bit again?
Yeah, the second part of the question was, and does it suggest, in terms of the finding, the intervention primarily preserved fat mass, and what modifications
Yeah,
to
I'm
more intensive resistance exercise might be needed?
yeah, I'm not sure you can comment that it would primarily preserve fat mass. I don't think we can comment much on that at all. Um, it's it's not necessarily about the type of exercise, it's a compliance to the exercise. So the compliance data haven't been presented yet fully, but our initial analysis from these data suggests that those who complied better with the intervention actually had meaningful improvements in lean body mass.
And we've got two very similar questions from Ahmed and Camila. Are there any supplements or proteins that patients can take in terms of in the early stage of diagnosis to decrease the risk of detrimental cancer cachexia development? And then Camila's asking a very similar question, which is there any evidence regarding the number of grams of protein that can be prescribed for patients with cachexia?
That's a good question. There's no there's no um there's no sort of hard data that suggests how what people should take. My philosophy is a basic one. I want people to take more energy, and I use the term energy, not calories, because energy's got a sort of positive connotation to it. So I would encourage patients to take high degrees of energy, so energy dense foods such as, for example, if they're going to have, milk, use full fat milk, if they're going to have, if they're going to have, a spread, use a butter, do you know what I mean? So it's these sort of things and trying to bring, almost like what we've been traditionally taught as a bad diet, into our system. So, we're taught through our life, that you should, not eat, foods that are high in saturated fats and high in calories, but actually, for people with cancer, what they need is extra calories and extra protein. So it's important that they they take, as energy dense and as protein rich food as they possibly can. In terms of, specifically protein intake, I mean, there are various figures quoted. There's different guidelines you can look at, such as the ESPEN guidelines, there's the ASPEN guidelines. For cancer patients, it's roughly about 1.5 grams per kilogram per day. So, if somebody who's 70 kilograms, that's about, 100 grams of protein a day. That's quite hard to equate to what patients actually do. So I would suggest that, thinking of, having foods that are high in protein, such as meat, fish, etc., chicken, which can all help boost their protein intake. Supplements, some people believe that omega-3 supplements are helpful. We did in the MENAC trial a nutritional supplement containing omega-3. So I think there's a low risk of harm with those and a potential risk of benefit, but currently there's no sort of standard of care for these nutritional supplements across cancer.
Which is great because you've just tackled another question, which is about omega-3. So squeeze that one in. Thank you. Got a question from Aideen, which is this. Thanks for a great talk. Do you have any opinions on bimagrumab activin 2 receptor blockade in cancer cachexia?
So was that Visogramab, did you say?
Bimagrumab.
Bimagrumab. No, that's not one I'm aware of. No. So tell me what type of drug is that again?
I'm going to hand that one over to Aideen. Aideen, can you give us some more thoughts in the chat box, and we'll come back to that one. We've got another one here, which is for patients who progress to refractory cachexia, where the cancer is procatabolic and expected survival is under 3 months. The goals of care must shift. How do you recommend we adjust our approach to nutritional support in the refractory cachexia phase? And what are some effective ways to communicate that difficult transition from aggressive intervention to focus on quality of life with patients and families?
Simply put, I say to patients and families, only do things that are improve how they feel. So I generally don't. I'm not a big advocate of oral nutritional supplements near the end of life because generally, they can be quite unpalatable, and I'd much rather patients took food that they wanted to take rather than something that was, prescribed. A scenario that I do quite often come across is using dexamethasone, so corticosteroids near the end of life. I think these can provide some helpful boosts in both energy levels, mood, and also appetite. So that's an area where I do like to use corticosteroids. I do get concerned about people using them earlier in the cancer journey because they do cause muscle loss rather than muscle gain. So people being on sort of long-term low-dose steroids for cachexia, I'm not that supportive of at the moment.
And really similar kind of topic. Overcoming the fear of weight talk in inverted commas is a crucial patient level barrier. Could you provide some examples of how you would phrase or communicate techniques to introduce the topic of cachexia in a way that feels supportive and empowering rather than frightening for the patient?
Yeah, that's good. Yeah, that's a great question. The term cachexia is it's quite horrible because oncologists, I think, and healthcare professionals really associate it with end of life. Patients don't really know what it is. So one of the things I've learned from my practice is that patients are hugely grateful when you explain to them what they've got, why they've got it, and it's quite common. And there are various patient portals you can look at for information for that. But that acknowledging it of it has been a problem, the elephant in the room even, that's hugely beneficial for patients. So actually, I would turn that back on its head and say, actually, this is a thing that patients want you to bring up and are often really glad you've brought it up because it will help, improve their understanding of it, but also helps to sort of downplay some of the stress that can go on between the patient and the caregiver because of, the weight loss that's happening. So the patient's worried about it, the caregiver is concerned that they're not eating enough. That can cause stress and, resentment in a relationship. So that can really help as well. So I would say bring it up, ask questions on it.
And interesting question about electronic medical records. So for those of us working in large healthcare systems, are there specific EMR alerts or automated tools that you perhaps from your experience have seen integrated, a GPS calculator or a GLIM criteria checklist that have proven effective at overcoming clinical inertia?
So, short answer, no, I haven't seen anything that's become clinically effective. Um, the problem with a lot of these, like the guidelines for the guidelines apps, for example, the ESPN guidelines app, is basically the guideline, but basically on a paper form and in an app form, they're still not that user friendly. So I think at the moment a simple basic thing to do from electronic health records is look at weight and look at degree of weight loss. And that is usually routinely collected across most cancer settings, but rarely acted upon. So I think a simple thing like asking about weight and checking weight would be a very important step in the right direction.
We've heard back from Aideen. Aideen has followed up in the chat for us here. So she's pinged a link to JAMA in, which I can ping across to you as well.
Yeah.
Which says, apologies, bimagrumab is an activin 2 receptor blocker that was studied in obesity/type 2 diabetes and showed loss of fat mass and increase in lean mass. And there was some interest in using this for cancer cachexia also. And her original question was, do you have any opinions on bimagrumab activin 2 receptor blockade in cancer cachexia?
No, but thanks for raising it.
Um,
I think a lot of these. I think a lot. Oops. Hello.
Go ahead, Prof. Laird, sorry.
No, I'm just saying a lot of these drugs which have been used in other settings will actually probably have pathways in cachexia too. So look forward to hearing more about the story around this compound. I mean the agents which are being used just now to target the obesity epidemic, the Ozempic and the tirzepatide type drugs, those pathways are extremely useful in causing loss of fat mass, but also lean mass. So you do wonder if this pathway could be targeted in the reverse way to actually improve, fat mass and also lean mass.
Sure.
Remains to be seen.
Sure. It's an interesting conversation, right? And then one last question, perhaps, if that's okay. We'll squeeze one more in, which is looking at the comprehensive research landscape that you've presented, what do you believe is the single most pressing question that future cachexia clinical trials need to answer that's going to change day-to-day oncology practice? Is it novel therapeutics, refining non-pharmacological interventions, or identifying predictive biomarkers to personalized treatment?
It's a great question. If I have to pick one, it would be none of those, but they're all really good suggestions. It would be getting an endpoint for a clinical trial that the drug regulators find acceptable. So that to me is the holy grail at the moment, finding an endpoint that is acceptable to regulatory bodies.
Great. Professor Laird, thank you so much for joining us today and for tackling so many questions, as well as two fantastic sessions covering each learning objective today. Thank you so much for joining us.
Thank you.
If you are able to, I'm going to bring up a QR code on the screen to scan the QR code if you're joining on desktop. I've popped a link into the chat box. If you are joining on mobile, you can click the little message icon at the bottom and you'll find a link to the feedback form and the ability to claim your CME certificate. Really important. In the chat box, you'll find the link right there. If you're joining across social media, you'll be able to scan that QR code and claim your CME certificate. It's completely free, and we would really appreciate your feedback as well. Our goal here at Medal is to make medical education radically accessible, free, open access to colleagues around the world. I hope you find this session really helpful and useful. And we actually have another session coming up in cancer cachexia on October 1st. And I will pop the link to that session into the chat box as well. And you'll be really welcome to join us at that session. And it's also completely free. You are able to join it by registering in the link that I've just popped into the chat box. And you'll be very warmly welcome at that second session in cancer cachexia. And that just leaves me to say thank you once again to Professor Laird for joining us for such an incredible session and tackling so many cancer cachexia questions from across our different channels. and to thank all of you, our audience and colleagues today for joining us. I hope you find it useful. I hope you'll join us at our second session. Don't forget to click the link and to claim your CME certificate. We'll bring the QR code up on screen once we're finished again, and you'll be able to scan that and claim your CME certificate. Have a great rest of your day, and we hope to see you soon. Thank you.